Hi, this is Brian Shapiro from CTA Pathology, and welcome everyone. I hope everyone is keeping warm and keeping safe in these times of COVID and bad weather. And tonight's talk is going to be on the histiocytoses. So this is a confusing subject, and there's been quite a lot of new developments in the histiocytoses. So what I'm going to try and do is go through the new classification of the histiocytoses, which is just out the last few years, and for once kind of simplifies things, making things more easy to understand than previously, and then show some slides from a past presenter, because some of these are incredibly rare diseases that are not often seen, and then some slides from our own practice that we can see as well. So I first put together a little PowerPoint on just the classification. So in the journal Blood in 2016, there was an international group that put together a new classification of the histiocytoses, which are neoplasms of the macrophage dendritic cell lineage. And I'm going to go through this because this is probably not common knowledge. So let's... So the histiocytoses, the lineage of these, they're members of the mononuclear phagocyte system. And histiocytoses are essentially accumulation of cells from dendritic cells or from macrophages that are derived from these. The macrophages, as you all know, are oval cells with clear to pink cytoplasm, which phagocytoses debris and pathogens in the reticular endothelial system and in the skin and liver and other sites. And dendritic cells are the antigen-presenting cells, which present antigens in conjunction with a major histocompatibility complex to activate T lymphocytes. And the dendritic cells can be divided into the myeloid dendritic cells and the plasmacytoid dendritic cells. And one subgroup of those is the Langerhans cells, which we know well because they're in the epidermis and mucosa. And so those are the main antigen-presenting cells in the skin. So the new classification of the histiocytoses is on this slide. The first group is the Langerhans cell group. And in that group is Langerhans cell histiocytosis and intermediate cell histiocytosis, and then Erdheim-Chester disease. And fourthly, there's a mixed group where you have Erdheim-Chester and Langerhans cell histiocytosis together. So this group, for Langerhans cell histiocytosis, there was leprosy disease and eosinophilic granuloma and all kinds of different names. And these are all just now being grouped as Langerhans cell histiocytosis. And the two that we see most commonly are Langerhans cell histiocytosis and Erdheim-Chester or Erdheim-Chester-Langerhans overlap. The second group are the cutaneous and mucocutaneous group, and this one includes the xanthogranuloma types and the non-xanthogranuloma types. So that's the cutaneous or mucocutaneous group. The third group is the Rosai-Dorfman group. And then the last two, which I'm going to say very little about, are the malignant group and the hematophagocytic group, and we don't see those often in the skin. So those two we won't discuss much. So let's move on to the first group, the Langerhans cell group. And the most common one here is Langerhans cell histiocytosis, which we all know that can affect any organ in the body, often in children, and can have involvement of the liver, spleen, pituitary gland, often lungs. Erdheim-Chester disease, which I'll go into, but this has systemic involvement. And then two relatively rare ones, the indeterminate cell histiocytosis and extracutaneous juvenile xanthogranuloma. So in this new classification, even though extracutaneous juvenile xanthogranuloma is a xanthogranuloma, it's in the Langerhans group. Langerhans cell histiocytosis and Erdheim-Chester disease both have been shown to have clonal mutations involving the MAP kinase pathway, more than 80% of cases, and both can have diabetes insipidus. So if we look at Langerhans cell histiocytosis, this can vary clinically from a self-healing disease to life-threatening disease, can affect any organ, and often we see this rash in the genital areas, erythematous plaques with scale sometimes. The pathology of this is, I'll demonstrate, but it's well known. It's epidermotropic kidney bean cells with a cleaved nucleus. They're often eosinophils in the infiltrate. It's a nodular dermal infiltrate, and the cells are CD1A positive and, importantly, CD207 negative. And this is to determine this, to distinguish this from the very rare indeterminate cell histiocytosis, you do a CD207 stain. Once you've diagnosed Langerhans cell histiocytosis, if it's a skin biopsy, then there obviously has to be a workup for systemic involvement. So now I'm going to move to the next one of the Langerhans group, Erdheim-Chester disease. This usually presents in adults about mid-50s. Occasionally, pediatric cases have been reported. It's made with histology and clinical and radiological tests. Skeletal involvement is greater than 95%, and PET scans are very effective and specific to diagnose the skeletal involvement. Often there's cardiovascular involvement, about 50%, and importantly, there's retroperitoneal fibrosis. Now, in Erdheim-Chester disease, clinically, the most common cutaneous manifestation is xanthelasma. Erdheim-Chester can affect any organ, the bone, the skin, the liver, the pituitary, lung, and again, is an erythematous rash, often in the genital area. Sorry, that's not often, but it can have that. So the pathology for this is not specific, but it's mandatory to do a biopsy. If you see a xanthelasma-like lesion, then the histology is just going to be like xanthelasma. But otherwise, other lesions have got fomeohistiocytes with multinucleated or Teuton-type giant cells. There's fibrosis, there's plasma cells and neutrophils. Importantly, CD1A is negative, and you can find eosinophils in the infiltrate. Now, interesting, about 20% of Erdheim-Chester disease patients have Langerhans cell histiocytosis-like lesions in the same biopsy. So that's that overlap we were speaking about. And it's important to be aware of this when you do the stains on the biopsies. Okay, so those are the two ones I want to talk about in the Langerhans cell histiocytosis group. The next group is the xanthogranuloma family. And in this, the next group is the cutaneous, mucocutaneous histiocytoses, and the first subgroup of that is the xanthogranuloma family. So this group has got solitary or multiple or disseminated lesions. It's named depending on what part of the body is involved and the age of the patient, juvenile versus adult. So in this group is a whole panoply of different diseases, but they all fit into the xanthogranuloma family. The juvenile or adult xanthogranuloma, benign cephalic histiocytosis, solitary reticular histiocytoma, generalized eruptive histiocytosis, progressive nodular histiocytosis, xanthoma disseminatum, and purely cutaneous Rosai-Dorfman. So importantly, purely cutaneous Rosai-Dorfman, they have put into the cutaneous, mucocutaneous group of the histiocytoses. This is kind of complicated, whereas systemic Rosai-Dorfman is the third group of its own, which is Rosai-Dorfman disease. The important ones we see biopsied are either a juvenile or adult xanthogranuloma, a solitary histiocytoma, xanthoma disseminatum sometimes, and cutaneous Rosai-Dorfman. The pathology of these is all similar. It's a mononuclear cell infiltrate. It spares the epidermis in contrast to Langerhans cell histiocytosis. They're foamy cells, Teuton-type giant cells, eosinophils. And when you get reticular histiocytomas, they're oncocytic cells with ground glass cytoplasm in a solitary reticular histiocytoma. The histology of purely Rosai-Dorfman is different. This is a dermal infiltrate with darker and lighter areas. You see histiocytes, plasma cells, neutrophils, giant cells, and this phenomenon, imperiopoiesis, which is engulfment or phagocytosis of neutrophils or lymphocytes by some of the giant cells and histiocytes. Importantly, for staining, this is S100 positive and 68 and CD1A negative, in contrast to Langerhans cell histiocytosis, which is CD1A positive. So that's that next group. The second subgroup of the cutaneous mucocutaneous has got a few entities. The first one is a necrobiotic xanthogranuloma, and these, as you know, are usually yellow indurated plaques around the eye associated with telangiectasia and atrophy. They can ulcerate, and importantly, they have paraproteinemia, and they often can be systemic involvement with cardiac or hematologic involvement. So if you make a cutaneous diagnosis of this, you need to do systemic workup. The pathology of this is necrobiosis of the dermis with and the paniculus, plasma cells, giant cells, histiocytes, their cholesterol clefts, and then dense lymphoid infiltrate with often germinal centers. And I'll show some pictures of that. The second one of this non-xanthogranuloma family is multicentric reticular histiocytosis. This is women 50 to 60. You often have these coral beads in a periungual location with papules on the extremities. There's a destructive arthritis, and it's associated with malignancy and or autoimmune disease. It looks just like a cutaneous reticular histiocytoma, just the clinical presentation is unique. So you have oncocytes, macrophages with that oncocytic ground glass cytoplasm, and giant cells. And the third group is the Rosai-Dorfman group, which I'm going to not discuss because this is systemic Rosai-Dorfman. And then the last two of the classification are malignant histiocytoses, and all we'll say about that is that these are rapidly progressive disease, and a pathology is anaplastic cells, which are, you have to do immunohistochemistry because they can look like a carcinoma or lymphoma, so you need keratin, lymphoid, or melanoma, melanocytic markers. So let's just go back to this classification before we start the slides. The first group is the Langerhans cell group, which is Langerhans cell histiocytosis and Erdheim-Chester. The second is the cutaneous or mucocutaneous group, where the first subtype is the xanthogranuloma group, and those are adult or juvenile xanthogranuloma, reticular histiocytoma, and importantly in this, purely cutaneous Rosai-Dorfman. And then the second would be the non-xanthogranuloma group, where I did necrobiotic xanthogranuloma is in that one. The third, fourth, and fifth group, so we're not going to discuss, which is Rosai-Dorfman group with systemic involvement, malignant histiocytosis, and hematophagocytic syndrome. So let us look at some slides now. Sorry, Ethan, can you just edit out that before I started this slide? I'm going to start again. So we're just going back to this classification of the histiocytoses before I show some slides. The Langerhans group, which is Langerhans cell histiocytosis and Erdheim-Chester disease. Then the cutaneous mucocutaneous group, where there's the xanthogranuloma group. And remember, that includes juvenile and adult xanthogranuloma, reticular histiocytoma, and others such as benign lymphatic histiocytosis. The non-xanthogranulomous group, which is cutaneous Rosai-Dorfman, necrobiotic xanthogranuloma, and also in this group is multicentric reticular histiocytoma and xanthoma disseminatum. So those are in the non-granuloma group. So now we are going to look at some slides. First case is this. It's a nice shave biopsy. Can't really tell where it's from. And even at this power, you can see the action is in the dermis. And they are mononuclear cells. And when you look, some of them are cleaved. They have this line that you can see in the nucleus. Some have got a kidney bean shape. You see this one here. Often they're eosinophils here, and you find epidermotropism. You see these cells here are epidermotropic, and this is Langerhans cell histiocytosis, often in children. Here's the eosinophil. Next slide. It's taking a while to load. Oh, let's go to the third one. So here's a similar case, a little bit of hyperorthokeratosis, maybe some lichen simplex chronicus, and even at this power you see a dense pandermal infiltrate with mononuclear cells, and even here, medium power, you can see a lot of eosinophils. Now, when you look at these cells, you might think, with the eos, are they mast cells? Could this be a mastocytoma? Could this be a melanocytic lesion? But when you look carefully, many of them are cleaved, and they have, some of them, a kidney bean or molded, elongated nucleus here. And this was another case of Langerhans cell histiocytosis. And then dividing this and subclassifying depends on systemic involvement and the workup. The next case was on the scalp. And again, you can see a pandermal infiltrate. This one, you can see quite a few giant cells. Again, a lot of eosinophils, and these characteristic mononuclear cells, large oval to elongated nuclei, cleaved. And this doesn't have much epidermotropism, but that's another characteristic of Langerhans cell histiocytosis. So when you see a lesion like this, especially if in a young kid, and the clinical fit do the stain, and the stain with this will be CD1A positive, S100 negative. So that's Langerhans cell histiocytosis. You can see a bit of a lymphoid infiltrate, and remember, for Erdheim-Chester, you can see areas that look like this as well, where they CD1A positive. So the next is a clinical photo. Most people will probably know what this is. It's a yellow to erythematous, well demarcated nodule. It was in a young child, and this is a classic juvenile xanthogranuloma. And here we have this histology, which everybody probably knows well. Nice punch biopsy with the dermal process, again mononuclear cells, but these ones do not have the cleave that you see in Langerhans cells. You often do find eosinophils with these, and you find these classic Teuton type giant cells, which is a wreath of nuclei surrounded by a foamy ring. Let's just look around and see if we can find any of this. These do not have epidermotropism. Here's one, it's not in good shape, focus, but it's a wreath of cells. And I think I've got some other cases of this as well. Here you can see this was a nodule which is protruding out, very well demarcated. Dermal process with mononuclear cells. And here we have these most beautiful Teuton type giant cells. Pink in the middle, a wreath of nuclei surrounded by foamy cells. And then together with this, you find these mononuclear cells, these histiocytes. Some are foamy. Later on, they get more ground glass cytoplasm, and this is why they put this group of the cutaneous, mucocutaneous histiocytoses together, because sometimes they described scalloped cells, and these are all just on the spectrum of histiocytes which start foamy and then can get amphiphilic cytoplasm. Here's another picture of a classic, this yellow erythematous, yellowish papule child. And here's another nice picture of one. Again, a shave biopsy, a little bit of epidermal hyperplasia. And when you look on high power, if you get this in boards and you see these kind of cells with the wreath of nuclei, the foam, eosinophils over there, this is a xanthogranuloma, juvenile or adult xanthogranuloma. So the cousin of this one is the reticular histiocytoma. And this, as you can see, is a very similar dermal process with replacement of the dermis by a dense cellular infiltrate. And these cells, you're not seeing Teuton-type giant cells, you're seeing this very pink cytoplasm. See? This ground glass is the buzzword for it, together with lymphocytes, sometimes eosinophils, giant cells you definitely can see. And these kind of oncocytic cells are reticular histiocytoma. Now, whether to classify this as a solitary reticular histiocytoma or multicentric reticular histiocytosis with, arthritis and potential malignancy and autoimmune disease, you really need to have the clinical information and scans and things. Here's yet another reticular histiocytoma. And again, you can see these mononuclear cells with this pink cytoplasm. This is fairly characteristic. And these can be misdiagnosed as Spitz nevus because Spitz has these epithelioid type cells with pink cytoplasm. Carcinoma, people think of. It could even be a sarcoma, a epithelioid sarcoma. So that's all stuff you must think about when you see these mononuclear cells, and you would do the stains. These would mark up with CD68, and they'd be negative with S100. And obviously, if you're looking for Spitz, you would look at the epidermis and see if there's any kind of nested proliferation up here, which there isn't. So this is a perfect picture of a reticular histiocytoma. And this I'm just putting here because this turned out to be a patient with multicentric reticular histiocytosis who had arthritis. And again, here you can see they're exactly these same kind of ground glass mononuclear cells with a distinct nucleolus. Some of them have got some foaminess and some eosinophils, and a few neutrophils even in the infiltrate here. So you really need the clinical to distinguish these. I'm just going to show a picture of one we never see, but this is a disease called benign cephalic histiocytosis. Often it's in children, multiple papules. And the histology of this is just this, as you would see in a xanthogranuloma. Foamy histiocytes, eosinophils, sometimes Teuton-type giant cells. Here's one. See that foaminess, and they're the nuclei. They're not so well. Here's another one. And here's another picture of this. And these, again, you have to have the clinical because, as you can see, in the xanthogranuloma family, it's either xanthogranulomatous or reticular histiocytoma-like, and then the division. So the next one is Rosai-Dorfman. And these can present in a multitude of clinical ways, but here we have a red papule. And this is a fairly characteristic histology as well, which also is something they like on boards. And these ones at low power, you see areas that are darker, which is the lymphocytic infiltrate, and then areas that are lighter, which is the histiocytic infiltrate. When you go and look at these, this is something like we haven't seen yet, because you've got these darker areas here of lymphocytes, and then these lighter areas of histiocytes. And you also have giant cells, foamy giant cells. And if you look carefully inside these histiocytes, there's a lymphocyte inside the histiocyte. And I'll show you better examples of these. But these little blue cells inside the cells with the pink cytoplasm are the lymphocytes which have been imperiopoliced or imperiopolesis. So the other histiocytoses we've shown up till now have not had these kind of two-tone look. And often a very dense lymphoid infiltrate over here. You can see. And then here you can see these cells with the engulfed lymphocytes, these little blue ones. Just going to show a few more of this because this is a useful one to know. Again, on low power, you see the lighter areas and the darker areas, and this well-defined nodule, no epidermotropism. You go on high power, you see these are all histiocytes. And here you can see nicely these neutrophils, lymphocytes, all inside the cytoplasm of the histiocyte here as well. And then in the darker areas, which are over here, we're seeing some of them, you can see it's a dense lymphoid infiltrate. So this is a fairly characteristic picture of Rosai-Dorfman. The next under the same group, which is the mucocutaneous, cutaneous, non-xanthogranulomatous, is this one, which is also fairly characteristic. So this, we're seeing a shave biopsy, and we're seeing something we have not seen before, which is in the middle here, you've got cholesterol clefts. See here, where there's cholesterol that's been dissolved out in processing, and these are cholesterol clefts. And then you've got necrosis of the dermis. There's no real normal collagen. And again, a mixed infiltrate of these mononuclear cells with giant cells. And often in this disease, very, very dense lymphoid infiltrates, which I'm not seeing in this as well as in some of them. But these cholesterol clefts with necrobiosis are absolutely characteristic of a necrobiotic xanthogranuloma. So you've seen xanthogranuloma, you've seen reticular histiocytoma, you've seen Rosai-Dorfman, you've seen necrobiotic xanthogranuloma. All have got diagnosable histology, this cholesterol clefting. Here's another necrobiotic xanthogranuloma, some epidermal atrophy, zones of necrosis. You can see even at this power going into the panicculus, complete loss of the normal dermal architecture. And then a mixture of these histiocytes surrounded by dense lymphoid infiltrate. And this one doesn't have the beautiful cholesterol clefts, but if this came from the eyelid and you see these areas of dermal necrobiosis, this can only be a necrobiotic xanthogranuloma. Maybe some fat in here that's dissolved down. Now look, you see the necrobiosis of the dermis here. The collagen bundles are destroyed. Okay, so this clinically everyone will recognize as xanthelasma, and these are associated with hyperlipidemias. But the interesting thing here is that sometimes these are seen in Erdheim-Chester disease, and that's why I put them here. So before we just write this off to xanthelasma, which it is clinically and histologically, we should think of this Erdheim-Chester. And here is a picture of xanthelasma, usually on the eyelid. And you can see very little infiltrate, and these foamy cells, these are characteristic, small nucleus and all the little foamy bubbles, lipid droplets inside the cells. And this is very characteristic of a xanthelasma. I've got a few others here. It's a very pale one, but even on these pale slides, when you go up, you can see the foaminess of the cell. Now, eruptive xanthoma, this can look exactly like a xanthogranuloma. So this is an eruptive xanthoma, and it looks just like a xanthoma or xanthelasma. You see these foamy cells. So this is eruptive xanthoma, which is not in the classification of the histiocytoses. I just wanted to show you, neither is xanthelasma, but I want to show you that these are a different histology. So these are xanthomas, and there's tuberous tendinous, plain, diffuse, normal, lipemic, and they all look the same. They all have xanthoma cells, and they're not part of the histiocytoses, xanthomas. And here's one they love on boards. On low power, you see some papillary hyperplasia-like pattern, and then these divots of parakeratosis pushing into the epidermis. And this is a classic pattern that you see. When you see that, you look for foam cells in the papillary dermis. And there they are. So this is a verruciform xanthoma. And once you've seen this a couple of times, you look at this and you think, oh, could this be porokeratosis? But it's not, because there's not disc keratotic cells underneath the column of parakeratosis. And you just look at this and say, oh, verruciform xanthoma. And these, as you know, you can find in the oral cavity, on the scrotum, buttock, and it's a very nice slide for the boards. Here's yet another one. Same papillary hyperplasia with these parakeratotic V-shaped, often pointing into the epidermis. And when you look here in the papillary dermis, you can see it's a beautiful verruciform xanthoma. Look at the foamy cell. Okay, so while I was here on Path Presenter, I could not resist giving another slide, which is a new entity and is not one of the histiocytoses, but it's related. And this is IgG4 disease. And this presents with fibrosis and a dense plasmacytic infiltrate, and they all stain with IgG4. So this was a slide I came across, and this is retroperitoneal. It's not in skin. I just put it in here because it's something that we should be aware of. It's kind of been topical lately, and IgG4 disease is something to just know about. So I'm going to show some of our cases. The first one here is an adult, a lesion on the nose. You can see a lot of sun damage and a mononuclear cell infiltrate with giant cell formation and some wreath-like pattern. Let me see, here's one. It's a giant cell with a wreath, almost two-ton-like. There's one starting. Here's a nice two-ton type giant cell. There was some eosinophils in the infiltrate, and this was an adult xanthogranuloma. So here's a nice one which you should recognize, a shaved biopsy, some papilloepidermal hyperplasia, and these pink spikes going into the epidermis. When you look, it's parakeratotic scale here. And remember, when you see that pattern, go look in the papillary dermis, and you find all these foamy cells. So this is a classic verruciform xanthoma. Now, interesting here, it's a little subtle, but if you look at the edge, you see there's no real normal stratum corneum. And you can see there's no hair, there's no eccrine glands. So this is a verruciform xanthoma with these foamy cells in the oral cavity, which is a pretty typical location for them. So here's our next case. This was a kid with a yellow papule on the cheek, a big dome-shaped dermal process with some inflamed scale crust on top, eosinophils, and the most beautiful two-ton type giant cell you can see. And you can see some of these are foamy and some are more pink, like a reticular histiocytoma. That's why they put them in the same classification. There's another beautiful two-ton giant cell, eosinophils, juvenile xanthogranuloma. And here's just a slide of another one, looks the same. And you can see once you get the hang of it, you just go straight to these cells. A few more of them, some lymphocytes, eosinophils, xanthogranuloma. So this one's the same, but yet a little different. Again, a shaved biopsy, epidermal atrophy, a little bit of hyperorthokeratosis, and a dermal process with mononuclear cells and lymphocytes. And these cells, you can see, have got this pink cytoplasm. They don't have the foaminess. So this one would fit into the reticular histiocytoma or multicentric reticular histiocytosis. You can see, you can think of a spitz over here. Big nuclei, distinct nucleoli, pink cytoplasm. And again, the usual mix of inflammatory cells, lymphocytes mainly. So this was a reticular histiocytoma. I think here we have, just to show this nice ground glass cytoplasm. This would be a perfect field for reticular histiocytoma. And this is the last one of our slides. Again, these present all the same way with a dermal nodule. This one's maybe ulcerated. Don't know where it's from, but maybe the scalp with these terminal hairs. And on low power, this is hard to appreciate, but you can see there's some more pinker areas and some darker areas. So this is different from the things we've been seeing up till now. When we go on high power, there are a lot of giant cells here, but here we really have got dense areas of lymphoid infiltrate. You can see here. And when you look carefully at this, I think here, how dotted it goes. Have these giant cells, and inside the giant cell, you've got a lymphocyte right there. And inside some of these other mononuclear cells, you have neutrophils. So this is imperopoiesis. You've got some eosinophils. These don't help. But to just get the diagnosis from this, I think would be very difficult to be definitive. So the next things you need are special stains. And I'm going to show you some of those now. So stains we do here are S100, CD1A, and maybe CD207, and maybe CD68. But CD68 stains all histiocytes, so that's not really useful. But here you can get a sense that inside the nuclei, inside the cytoplasm of some of these cells, you've got neutrophils. Look there. So this is engulfment of the inflammatory cells. So let's just show this. This is the S100, and you don't even have to go up to high power because you can see all these mononuclear histiocytic cells are S100 positive. Beautiful stain. So this is S100 positive with imperopoiesis. This is Rosai-Dorfman disease, and they are CD1A negative. And this is the CD1A stain. You can see dead negative. So that's Rosai-Dorfman. So I think you can, after this, easily diagnose Langerhans cell histiocytosis, Rosai-Dorfman, xanthogranuloma, necrobiotic xanthogranuloma, reticular histiocytoma. Those are the main ones we see. And then just to know if there's fibrosis and bone involvement, Erdheim-Chester. And then just for a little bonus, I thought I'd show some recent articles from JAD. This is on Erdheim-Chester disease. It shows this part could be Langerhans cell histiocytosis. And this was Langerhans cell histiocytosis like lesions in Erdheim-Chester. Here's between a web space of the foot. Here you can see perianal, and this is intertriginous areas, the scaly erythematous plaques. So that could be Langerhans cell histiocytosis. This patient had xanthelasma, so that's always a clue for Erdheim-Chester. And he had tumoral lesions on the flank as well. And then lastly, I just wanted to show you not everything that's foamy is in the histiocytic chapter. And this is a beautiful clue for a disease called Fox-Fordyce disease, which is apocrine miliaria, and it's often very, very hard to find the apocrine epithelium on the slide because of how, our sectioning is. And one of the clues to Fox Fordyce disease is perifollicular foam cells, xanthomatous cells. So if you see what looks like xanthelasma and it's in the axilla, think of Fox Fordyce disease, because it's a difficult diagnosis to make histologically, given the focal nature of it on the apocrine epithelium. And when you see these foam cells around the epithelium of the follicle, that's a clue to Fox Fordyce disease. So that's all now. And I will send out the article, this review of the classification of the histiocytoses, and thanks for joining us.